Okay, let's unpack this. Today's deep dive is taking us into a highly specific and honestly rarely discussed intersection of aesthetic dermatology and, well, functional gynecology.
Yeah, it's a really unique area.
Right, because we're investigating a medical question that, I mean, it might sound incredibly surprising at first. We're looking at whether labial majora filler augmentation,
Hmm.
which is a procedure that's, routinely dismissed as just purely cosmetic.
Right, completely dismissed by a lot of people.
Yeah. Can it actually reduce severe vulval irritation that's caused by chronic contact dermatitis and urinary incontinence?
Yeah, it's such a fascinating paradigm shift, really.
It is, yeah. Because we've synthesized a mountain of clinical studies, dermatological reviews, and aesthetic clinic data to try and understand how restoring the physical anatomy of the vulva can essentially repair a broken biological shield.
Exactly. I mean, we are examining how a treatment that's historically been labeled by some as just, mere vanity,
Mhm.
is demonstrating profound functional medical benefits for a condition that severely impacts the daily mobility
Yeah.
and just the comfort of a massive number of women.
Yeah, and to really grasp the physics of what is going wrong here, I think we need an analogy. Like, imagine you just bought a brand new high-tech rain jacket.
Okay, I like this.
Right. So it's hummed, top of the line. It's engineered to completely repel water. You wear it out in a heavy storm, and the water just beads right off.
Right, it does
Uh,
exactly what it was built to do.
Exactly. But now, imagine you wear that same jacket every single day, and it is constantly exposed to a steady, nonstop acidic drizzle.
Oh, man, yeah.
And on top of that, you're wearing this heavy backpack with coarse straps that are just constantly grinding against the wet fabric.
Right.
Day in, day out, just chronic moisture and relentless friction. Eventually, no matter how advanced that fabric is, the waterproofing fails.
Yeah, it's going to break down.
Right, the material breaks down, the moisture seeps through, and the jacket is functionally ruined.
That analogy perfectly captures the mechanical and chemical reality of the vulvar microenvironment. I
Yeah.
mean, it really does.
Yeah.
Yeah, because no matter how resilient the skin barrier is naturally,
Mm.
um, chronic moisture combined with mechanical friction will just inevitably destroy its structural integrity.
And when we translate that ruined jacket to, human biology, we are talking about vulvar contact dermatitis or VCD.
Right.
And I was absolutely floored to realize that this specific condition is responsible for 20 to 30% of all visits to specialized vulvar clinics.
It's huge.
Yeah, 20 to 30%. That is not a niche issue. That is a massive hidden epidemic that's affecting women's daily lives.
It is. It is entirely debilitating. The vulvar skin is uniquely vulnerable because it's this highly sensitive barrier, but it's subjected to one of the most challenging environments on the human body.
Right, right.
Tends naturally exposed to some moisture, from sweat and normal glandular discharge. But the critical factor, the steady acidic drizzle from urinalygy that tips the scale into severe chronic dermatitis is often urinary incontinence.
Oh, I see.
Yeah, when the delicate skin is continuously exposed to urine, you develop a severe subset of VCD known as incontinence-associated dermatitis, or IAD.
Okay, so let's break down the actual chemistry of that exposure because, urine isn't just harmless water.
No, not at all.
Right, so if someone is experiencing urinary dribbling, they are essentially bathing that sensitive tissue in a chemical cocktail that actively attacks the skin.
Exactly. The chemical breakdown is just brutal on human tissue because urine contains urea.
Right.
And when urea sits on the skin, local bacteria break it down into ammonia.
Oh, right. Okay.
And that ammonia drastically raises the local pH of the skin. It completely disrupts the skin's natural acidic mantle.
Wow. Okay, so it alters the whole environment.
Yeah. But that alkaline environment does something even more damaging.
Thanks to that.
It activates digestive enzymes that are present in trace amounts of feces and urine.
Wait, really? So the altered pH acts like a trigger that turns on these digestive enzymes?
Yes, exactly.
Yeah.
Enzymes like lipases and proteases.
Okay.
In a normal environment, they're totally inactive.
Right.
But in this highly alkaline ammonia-rich environment, they wake up. And they literally begin digesting the keratin and the protective lipid layers of the skin's outer epidermis.
Oh my gosh. That is terrifying. So they are like microscopic scissors just cutting away at the skin's structural proteins.
Yeah, that's exactly what it is.
So the outer layer of the skin is literally chemically melting away, and then you add the heavy backpack straps from our analogy, the mechanical friction.
It's the perfect storm.
Yeah.
You have chemically compromised tissue being subjected to the constant mechanical friction of,
Yeah.
walking, sitting, or wearing tight clothing.
Right.
The skin barrier completely denudes, which leads to chronic irritation, severe redness, weeping lesions, and just excruciating burning pain.
And the traditional medical response to this, I mean, it seems incredibly frustrating.
Oh, it is.
Right. Because the standard protocol heavily relies on topical barrier creams. Thick pastes containing zinc oxide or dimethicone.
Right.
But if the skin is actively being digested and subjected to friction, rubbing a thick paste on it, I mean, that feels like putting a Band-Aid on a bullet hole.
Yeah, well, those barrier creams, they attempt to create a synthetic occlusive layer, to artificially repel the moisture,
Right.
to give the skin a temporary reprieve to heal. But pragmatically, they are profoundly inadequate for severe cases.
I can imagine.
I mean, they're messy, they rub off immediately onto clothing or absorbent pads, and they require meticulous reapplication after every single episode of incontinence.
Right, which is just not practical.
No, it's not. They only treat the surface symptom, the chemical contact,
Right.
but they completely ignore the structural reason why the delicate skin is so exposed in the first place.
Which brings us perfectly to the core anatomy, because we understand the chemical attack and the physical friction, but, why is this highly delicate mucosal skin sitting directly in the line of fire?
Right.
This is where the body's structural shield comes into play. Let's look at what actually happens when the natural anatomical defenses essentially deflate.
Yeah, and what's fascinating here is the actual evolutionary purpose of the labia majora.
Okay.
Because in modern society, there's so much misplaced focus on just the aesthetics of this area.
Oh, absolutely. Yeah.
But biologically, the labia majora are highly functional, robust structures.
Right.
They are two prominent skin folds filled with loose subcutaneous tissue, smooth muscle, and crucially, specialized fat pads.
Okay. So fat pads.
Yeah. And their primary biological job is to tightly enclose the pudendal cleft.
Yeah.
They act as this thick physical cushion designed to shield the highly sensitive, delicate structures beneath them.
Like the labia minora.
Exactly. Labia minora, the clitoris, and the urethral and vaginal orifices.
So they are quite literally the body's built-in bumper guards.
Yes.
Like their whole job is to take the hit so the delicate inner machinery doesn't have to.
Precisely. And they also aid in directing urinary flow straight down and away from the body.
Oh, that makes sense.
Yeah. But like all structural tissues, they're subject to the ravages of time, hormonal shifts, and physical trauma.
Right.
Aging and menopause bring a severe, sudden drop in circulating estrogen.
Yeah, that changes everything.
It does. And this estrogen plummet, sometimes combined with the trauma of childbirth or significant weight loss, it basically starves the tissue. The labia majora lose their natural collagen matrix, their internal hyaluronic acid diminishes, and those crucial fat stores atrophy.
So the balloon just loses its air.
Yes.
The structure just caves in on itself.
We refer to it clinically as labia majora atrophy or hypotrophy.
Mm-hmm.
And when that prominent cushion deflates, it loses the physical volume necessary to enclose the cleft.
And that leaves the bank vault doors wide open.
Exactly.
Suddenly the labia minora, which are these delicate mucosal tissues that were never meant to bear external force, they protrude beyond the majora. I can see how that leads to an immediate mechanical crisis. If a woman with this atrophy is doing anything active, like cycling, taking a spin class, or even just wearing fitted clothing,
Yep.
that exposed mucosal tissue is taking the full brunt of the friction.
It's taking all of it, yeah.
And worse, because the outer bumper guard is gone, there's absolutely nothing blocking the direct flow of urinary dribbling. It just pools directly against the mucosa.
Right. The structural anatomy has failed. The loss of volume fundamentally alters the local microenvironment.
Wow.
And it allows those chemical irritants we discussed earlier to pool and just wreak havoc. It is a biomechanical failure manifesting as a severe dermatological crisis.
Okay, so this lays the groundwork for the actual medical intervention. We have a deflated labia majora, leaving delicate inner tissue exposed to severe friction in urine. And the clinical solution we are focusing on is using dermal fillers to rebuild that lost physical volume.
Yes.
But, and here's where it gets really interesting, and I have to play the skeptic here for a minute because I have a major reservation.
Okay, let's hear it.
If we have a patient whose skin barrier is completely compromised, right? Like we were talking about weeping lesions, severe redness, raw burning tissue.
Yeah.
Doesn't coming at that highly inflamed area with a needle and rapidly stretching the tissue with filler just, I don't know, cause massive physical trauma? Wouldn't that make the dermatitis infinitely worse initially?
You know, it is an incredibly logical concern.
Right, it just seems counterintuitive.
It does.
Oh.
But it's exactly why the technique and the depth of the injection are so critical. The filler is not being injected into the superficial inflamed dermis where those weakening lesions actually are.
Oh, okay.
It is injected much deeper into the subcutaneous space, completely bypassing the irritated surface tissue.
I see, so it's underneath all the damage.
Right. By revolumizing from underneath, you provide immediate structural relief. Yes,
Right.
there's mild injection trauma, but it instantly lifts the inflamed tissue away from the friction source.
Oh.
You are stopping the mechanical grinding that very day, which finally gives the surface epithelium the spatial clearance it needs to heal.
So you are basically jacking up the foundation beneath a crumbling house to stop the floodwaters from reaching it.
That's a great way to put it, yeah.
Let's dig into the actual material being used, specifically in trials like the Esalane study,
Okay.
because we are primarily looking at hyaluronic acid, or HA, like Deserial Plus. Now, the medical literature refers to HA as a glycosaminoglycan.
Right.
Break that down for us. What is that actually doing in the body?
Let's simplify that because it sounds like a mouthful.
It really does.
A glycosaminoglycan is essentially a massive, complex sugar chain that naturally occurs in our skin, our joints, and connective tissues.
Okay.
Its defining characteristic, its biological superpower, really is its affinity for water. It acts like a microscopic sponge.
So it just absorbs everything.
A single molecule of hyaluronic acid can bind and hold up to 1,000 times its own weight in water molecules.
Wow, 1,000 times. But natural HA dissolves very quickly in the body, right?
It does, yes.
So how does it act as a long-term structural shield if it just dissolves?
Well, that is where the laboratory engineering comes in.
Right.
The HA used in these fillers is what we call cross-linked.
Cross-linked.
Think of natural HA like a single string of yarn. You know, the body's enzymes can easily snip it apart and dissolve it in just a few days.
Okay.
Cross-linking chemically weaves those individual strings into a dense, complex net.
Oh, I get it.
Yeah, so it takes the body's natural enzymes anywhere from 12 to 18 months to untangle and break down that net.
So when a clinician injects this highly durable cross-linked HA sponge deep into the deflated labia majora...
It immediately binds with local water and restores the lost volume. By reinflating those outer folds, you structurally rebuild the protective cushion.
Right.
The labia majora plump back up, they meet in the midline, and they functionally conceal the labia minora once again.
You instantly recreate the physical bumper.
Yes, the one that intercepts the mechanical friction from clothing or a bicycle seat.
Yeah.
And to your earlier point about the chemical attack,
Right, the urine.
yeah, this restored closure physically blocks the direct spray and the pooling of urinary dribbling from reaching the deep mucosa.
It is quite literally rebuilding the waterproof rain jacket.
Exactly.
I mean, we are doing structural engineering on the human body.
Wait, where?
But looking at the clinical data, it seems the benefits go far beyond just, taking up physical space. The tissue itself actually changes after the injection.
That is the secondary and arguably more profound regenerative benefit. Because the HA isn't just an inert placeholder.
Right.
The sheer mechanical pressure of expanding the tissue with the filler, it stretches the local fibroblasts.
And fibroblasts are?
Fibroblasts are the cellular factories in your tissue that are responsible for manufacturing collagen and elastin.
Okay, the building blocks.
Right. So when they are stretched by the filler, they interpret it as a signal to get to work. This induces what we call de novo collagen production.
Meaning the injection actually tricks the body into building brand new collagen from scratch, right around where the filler was placed.
Exactly. You get the immediate volume from the HA sponge, and then over the next few months, your own body weaves a reinforced matrix of new collagen around it.
That's incredible.
And furthermore, because that cross-linked HA is constantly drawing in local water, it dramatically increases the deep hydration, turgor, and elasticity of the surrounding tissue.
This dual action, the physical shielding and the biological hydration, I mean, it explains a lot about the outcomes in the clinical trials.
It really does.
Because I noticed they heavily rely on the Female Sexual Function Index, or the FSFI, to measure success. And the scores for things like pain and arousal improved
The
dramatically.
improvements are staggering, and it
Oh.
makes perfect mechanical sense.
Yeah.
Yeah, by revolutionizing the labia majora to their natural closed state, you aren't just blocking external threats like urine, you're also trapping internal resources.
Oh, like the natural moisture.
Exactly. The area naturally produces lubricating secretions from local sweat and sebaceous glands.
Okay.
But when the labia majora are atrophied and gaping open, those delicate secretions instantly evaporate, or they're wicked away by cotton underwear.
Right. Which leads to...
Severe, painful dryness.
Er.
But rebuilding the midline closure traps that natural moisture. That internal hydration severely reduces dyspareunia, which is the medical term for painful intercourse, and fundamentally restores sexual function.
It's amazing how integrated it all is. You fix the architecture, and suddenly the surface moisture, the chemical defense, and the physical comfort all snap back into place.
Everything aligns, yeah.
But if I'm listening to this and I understand the structural logic, my next thought is going to be about permanence.
Naturally, yeah.
Right, because if this HA filler eventually gets dissolved by the body after a year or so, why not use something that lasts forever? What are the other options for rebuilding this barrier?
Well, if we connect this to the bigger picture of regenerative gynecology, there are alternative materials, but each comes with its own risk-reward profile.
Okay, so what's the most common permanent one?
The most prominent permanent alternative is autologous fat grafting, which is frequently combined with platelet-rich plasma or PRP.
And autologous meaning it's sourced directly from the patient's own body, right?
Yeah.
Like taking fat from the abdomen and moving it to the vulva?
Correct. A surgeon performs local liposuction, usually from the abdomen or inner thigh, purifies that harvested fat, mixes it with concentrated healing platelets drawn from the patient's blood, and grafts it deep into the labia majora.
Okay, and that's permanent.
The massive advantage here is that if the fat survives the transfer and establishes a new blood supply, the volume restoration can be permanent. It is highly regenerative because fat is rich in stem cells.
But the catch is the phrase, if the fat survives.
Right, that is the critical variable, because fat grafting is unpredictable.
Oh, really?
Yeah, a certain percentage of the transferred fat cells will inevitably die off a process called fat necrosis, and then it gets reabsorbed by the body. So a surgeon might overinject to compensate, leaving the area temporarily overly swollen, and you just have to wait months to see how much volume actually remains.
Oh, that sounds stressful.
And furthermore, it is a surgical procedure. It requires sterile harvesting, greater anesthesia, and a significant recovery period.
Okay, so a lot more involved. What about the other injectable we saw in the clinical reviews? Calcium hydroxylapatite.
CALI, yeah.
How does that work differently than the HA sponge?
Well, calcium hydroxylapatite falls into a category called biostimulators. Instead of just holding water like HA, HA is composed of microscopic calcium spheres suspended in a gel.
Okay.
When injected, the gel provides a little bit of instant volume, but the real magic happens over the next few months. Those tiny calcium spheres deliberately trigger a mild, controlled inflammatory response in the tissue.
Wait, so it intentionally irritates the tissue on a microscopic level?
Precisely. And that controlled microirritation sounds bad, but it acts like a massive alarm bell for those fibroblast cells we talked about earlier.
Oh, the collagen factories.
Exactly. They rush to the injection site and frantically weave a dense, thick web of natural collagen around the calcium spheres. It relies entirely on your body's own immune response to build the volume.
That sounds incredibly effective for long-term structure. But, I mean, what happens if the practitioner misjudges the anatomy? Or if the patient simply hates how it looks or feels?
Well, that is the exact reason why KKA is less commonly used in this highly sensitive area. It is unforgiving.
Unforgiving.
Yeah, if there's a complication, a nodule forms, or the patient is unhappy, there's no quick fix. You simply have to endure it while the body slowly degrades the calcium over a couple of years.
Oh, wow, a couple of years. That's a long time if you're uncomfortable.
Right. Which brings us right back to why cross-linked hyaluronic acid is considered the absolute gold standard for this specific functional treatment.
It offers a safety net that the others don't.
It absolutely does. HA provides safety, predictability, and, most importantly, immediate reversibility.
Reversibility is key.
Yeah. An HA treatment is an outpatient procedure, taking roughly 15 to 45 minutes.
Wow, that's fast.
Yeah. The clinician applies a topical numbing cream, followed by a localized injectable anesthetic, making the actual filler placement virtually painless. You get the immediate structural cushion, and it reliably lasts 12 to 18 months.
Right.
But the ultimate safety protocol is an enzyme called hyaluronidase.
The magic eraser.
Exactly. If there's any vascular complication, which is rare but possible, or if the patient experiences discomfort with the new volume, the clinician can immediately inject hyaluronidase.
And what does that do?
This enzyme aggressively attacks the cross-linked bonds we discussed earlier. It completely dissolves the filler and returns the tissue to its baseline state within 24 hours.
Wow, within 24 hours.
Yeah, that level of control makes the procedure incredibly low risk compared to surgical fat grafting or permanent biostimulators.
But to be totally transparent, I mean, even with a magic eraser, we are still injecting foreign material into a highly vascular area. What is the realistic recovery looking like for a patient who gets this functional HA treatment?
Well, patients should expect mild, transient side effects purely from the trauma of the injection itself.
Okay, like what?
Because the labia majora are so rich in blood vessels, roughly 80% of patients will experience localized swelling in the first 24 to 48 hours as the HA aggressively binds to water.
Right, because it's that sponge.
Exactly. Minor bruising is also common, generally resolving within 3 to 5 days.
That doesn't sound too bad.
No, it's very manageable. The standard protocol advises patients to avoid any intense local friction like spinning classes, horseback riding, or intercourse for about 72 hours.
Just to let it settle.
Yeah, this brief window simply allows the cross-linked HA net to settle, integrate with the local tissue, and lock into place without being mechanically displaced.
Makes sense.
But looking across the broad clinical trials, severe adverse events are exceptionally rare, and the long-term patient satisfaction rates are remarkably high.
So what does this all mean? We started this deep dive talking about a ruined rain jacket, right? A vital biological skin barrier entirely compromised by the relentless chemical attack of urinary incontinence and the mechanical grinding of daily movement.
Yeah.
For decades, the medical standard of care has been to just smear on messy zinc creams and hope for the best.
Which just doesn't work for severe cases.
Right. And while modern society often rushes to dismiss anything related to aesthetic gynecology as pure vanity or, Beverly Hills excess, the science tells a radically different story.
It absolutely does.
Yeah.
This is a profound example of how form dictates function in human biology.
Yeah.
When the structural form of the labia majora collapses, the defensive function fails.
Right.
By utilizing a dermal filler to surgically restore that specific architectural form, the biological function effortlessly follows.
It is literally using a cosmetic tool to build a highly effective, minimally invasive structural shield.
Exactly.
It intercepts the friction, blocks the chemical burn of the urine, and traps the body's natural hydration. I mean, it goes far beyond aesthetics.
Far beyond, yeah.
It is about giving women suffering from chronic contact dermatitis their daily comfort, their mobility, and their fundamental quality of life back.
And if we look to the future, this functional success raises an incredible boundary-pushing question about the limits of regenerative medicine.
Okay, lay it on me.
If we have decisively proven that injecting cross-linked hyaluronic acid can fundamentally rescue a failing microenvironment,
Right.
if we know it provides an immediate physical bumper, stimulates thick new collagen, and deeply hydrates the tissue to block harsh chemical irritants,
Yeah, what's the next step?
could this localized injectable barrier concept eventually be adapted? Could clinicians start utilizing these dermal fillers to treat severe chronic contact dermatitis in other highly vulnerable, friction-prone folds of the body where traditional barrier creams have continuously failed?
Wow. Taking a cosmetic filler and weaponizing it as an internal biological rain jacket for chronic skin diseases all over the body,
Right.
it completely upends our entire understanding of what a filler is actually capable of.
It really does.
Next time you pull on a rain jacket, you might just think about structural anatomy in a whole new way.